afternoon, everyone, and welcome to the Center for Vaccine Preventable Diseases Fireside Chat. My name is Shelly Bolotin, and I'm the center's director. Before we begin, I wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work on this land. For those of you who are joining from elsewhere in Canada, I invite you to reflect on and acknowledge the land on which you live and work. Transparency in research is the key to public trust. So we'd like to note that the CVPD is supported by the Dalla School of Public Health at the University of Toronto. The school funds infrastructure and faculty and staff salaries through a mixture of operational funding, grant funding, and donor funding, including funds from vaccine manufacturers. We have a robust set of governance processes at the CVPD to ensure that funding sources do not impact the academic freedom of CVPD members. For more details about our funding and our governance, please visit our website. So today we are very fortunate to have Dr. Upton Allen, Sabina Vohra-Miller, and Joe Cressy with us to speak about their experiences working to improve vaccine equity and access during the COVID-19 pandemic through tailored strategies and effective communication. So in this fireside conversation, we're going to dive into successes, challenges, and ways to continue improving trust and equity in immunization. So I'll start off and introduce each of our speakers. Dr. Upton Allen is a professor of pediatrics at the University of Toronto and the head of the Division of Infectious Diseases at the Hospital for Sick Children, also known as SickKids. He's also a senior associate scientist in the Child Health Evaluative Sciences program at the SickKids Research Institute. Dr. Allen is past director of the Infectious Disease Society of America and a fellow of the society. He's also a fellow of the American Academy of Pediatrics, the Royal College of Physicians and Surgeons of Canada, and a fellow of the Royal College of Physicians in the United Kingdom. In 2018, he was awarded the Order of Ontario, which is the highest honor awarded by the province of Ontario. During the pandemic, Dr. Allen worked closely with Toronto's Black communities to improve vaccine equity and access, and he will be sharing some of those experiences today. Sabina Vohra-Miller is a passionate science educator and advocate, and the voice behind Unambiguous Science, which is a highly respected science communication platform that has over 27,000 social media followers. With a background in clinical pharmacology and toxicology, she previously worked in biotechnology as a medical advisor. During the pandemic, Sabina also co-founded the South Asian Health Network, working closely with South Asian communities to improve vaccine education and access. She's also the co-founder of the Vohra-Miller Foundation, which focuses on improving the health of the planet and its people. And last but certainly not least, we have Joe Cressy, who is a former Toronto City Councillor for Spadina Fort York, where he championed investments for a more livable city, including affordable housing and childcare, public transportation, and efforts to combat the city's overdose crisis. He also served as chair of the Toronto Board of Health. In Toronto is the largest public health unit in Canada. And this happened during the COVID-19 pandemic when he worked to ensure the city's response was comprehensive, equitable, and effective. Joe joined George Brown College in 2022 as Senior Vice President of External Relations, Communications, and Real Estate Development, where he works to create partnerships that benefit the greater community. So, few housekeeping items before we kick off. We are going to have our fireside chat, and then afterwards we are going to have a question and answer period where our panelists will be happy to take your questions. There is a Q&A pod at the bottom of the screen, and it's open throughout the fireside, so please type your questions or comments there, and we'll answer them during the Q&A period. Okay, so after all that, I think that we are ready to kick off. And I think in order to really get into this conversation, we need to think back to 2020 when the pandemic started and we faced this huge task of protecting our population with public health measures and then implementing immunization programs as efficiently and equitably and rapidly as possible. And despite these efforts, there was high morbidity and mortality in equity-deserving groups, in some groups of essential workers, and in residents of long-term care homes. And at all levels of decision-making throughout the pandemic, there were many moving parts simultaneously. And I remember repeatedly hearing during this time that we were building the plane while flying it. So we had very little time to make important plans and decisions. And throughout, we were faced with really key questions like, how do we communicate the importance of vaccines to diverse groups? And how do you meet each group's specific needs? How do you increase trust of specific populations in the medical community, especially in the face of historical and ongoing systemic inequity and structural racism? And how do you coordinate a citywide pandemic response to rapidly reach everyone everywhere? So our panelists today were all leaders in these critical conversations, mostly in the Greater Toronto area, but also in social media, which has a much broader reach than just our city. And we're really honored to have them gathered here today at the CVPD's first event of 2024. So Joe, I'm going to ask you to kick off. When COVID-19 vaccines became available at the end of 2020, you were given the task of implementing vaccine policy in a very large and diverse city. How did you approach that task to ensure vaccine program implementation was efficient and equitable?
Well, sure. And first of all, thank you for having me. And it's an absolute pleasure to join Sabina and Upton here, who are beyond impressive. They're spectacular. So from my perch, and I was the chair of Toronto Public Health and a member of our City of Toronto's strategic command team. Why don't I paint a bit of a picture? You sort of took us back to the end of 2020. Let me paint a picture of this context we were in, as I saw it at the city, and maybe where we ended up as opposed to where we began. So first of all, the prospect of a mass immunization drive in the city of Toronto represented what came to be the largest mobilization of any kind in the history of this city. There is no mobilization that I can point to in the hundreds of years of this city than the immunization drive. This city in Toronto, we're talking about a city of 3 million people, 200 different ethnocultural groups, a city where there's 180 languages spoken, where 1 in 5 adults live in poverty, 1 in 3 children, where you have 500,000 or so residents who are without status, undocumented, so to speak. That is a very large, diverse city on which we need to reach everyone everywhere. And that was the objective. When it comes to immunization, reach everyone everywhere. And what's interesting, if we go back to late 2020, initially with the variants we had at the time, the objective was herd immunity. And I remember in the earliest days, we were talking about if we can get 70% uptake, we will achieve herd immunity. Of course, later it became 90% uptake of 2 doses to achieve herd immunity. And then, of course, later still with variants, it became mitigation. Everybody needs to get shots because it's about protecting yourself, not preventing transmission necessarily. So, but put all that aside, and the objective in a city as large and diverse as ours is reach everyone everywhere. That's the objective. And we were in a city, in a society, and across many sectors who'd never done anything of this kind in short order before. So here's where we landed up. Not where we started, here's where we ended up. In order to reach everyone everywhere, there are sort of 5 pillars I would speak to. 1, it required a multi-sectoral approach. This wasn't the city, it wasn't the healthcare sector, it wasn't public health, it wasn't private institutions of partners and pharmacies, it was everybody. It wasn't the community sector. It was, we were only going to succeed if there was what we called a Team Toronto multi-sectoral collective leadership approach, number 1. Number 2, this was only going to succeed if you had an accessible clinic model based on reaching different people, from mass immunization clinics to hospital-based clinics to pharmacies to mobile to kids clinics. So you needed a multi-sectoral approach, you needed an accessible clinic model. The 3rd pillar was community-based outreach. You're going to meet people in a city as large as ours, you got to meet them where they're at. And in the city of Toronto, again, at this multi-sectoral level, the city was divided up into 12 clusters with 155 different community-based organizations doing on-the-ground outreach. 700 neighborhood ambassadors were all ultimately hired along with dedicated task forces in the Black community, the South Asian community, the accessible community. So multi-sectoral, accessible clinics, community-based outreach. The fourth pillar, ultimately where we got to, was a last mile election-based approach. Instead of getting out the vote, it was get out the vaccine. And that was literally trying to find all people who had yet to get shots and find out why, through phone banks and telephone town halls and door knocking. Was it a barrier that they needed to be broken down, access to a clinic, a ride to a clinic, linguistic challenges, or was it a trust issue and an education issue? So the last mile approach. And then finally, the fifth pillar I would just say is we wanted to build a movement. This was not just about protecting yourself or your peers, it was about being part of a collective expression of solidarity. That's a movement. And so, you know, things like clinics at the Scotiabank Arena to break world records for vaccines. Yeah, we wanted to deliver 27,000 shots in 24 hours, but it was more than that. It was about building a movement. So that's a picture just to set the stage of the city itself and the sort of, as I see it, the 5 pillars where we ended up. That is not at all where we began, but that's where it'll all begin, Shelly.
That's an excellent intro and I think quite inspiring, because in immunization in general, we want to build a movement. Joe spoke about how to approach program implementation in a really large and diverse city. But Dr. Allen, you were having important conversations at the same time with specific communities. So can you tell us a little bit about the work that you were doing with Black communities to understand rates of infection and specific community needs?
Thank you very much, Shelly. And it's a pleasure to be here with Joe and Sabina and you all. Thank you so much for having me. Shelly, I want to step back a little bit to when the pandemic started. I had concerns. The concern certainly from the Black community's perspective, in the sense that very early on, there were reports, social media, United States and elsewhere, that Black folks were not being affected by COVID. That for whatever reason, they were resistant to COVID, and this was in the media, and this was very concerning, because what we're looking at is the spread of misinformation very, very early on. So at that very early stage, myself and my colleagues, we identified the need to address that, to ensure that the Black community was being provided with correct information, that they were not immune to COVID at all. And there are lots of historical factors associated with that type of misinformation that we could go into, relating to smallpox and yellow fever outbreaks in centuries ago, where certain individuals thought that they were immune. So it was important for us to address that. So the main focus then initially was to ensure that we were getting correct information to the community. And we were also engaging the community in generating data from the community itself. And this was really important because what we were confronted with earlier on were situations where people were saying, well, I don't know anyone who had COVID. I hear about this in the news, but I don't know anyone with COVID. And so we needed to generate data to help to define the full extent to which COVID had penetrated into the Black community, and also to help define the factors that were associated with having had COVID. And so our initial work focused on seroprevalence information that would go beyond the case counts that come from positive PCR tests, but to look at antibody, to go beyond that, to look at identifying the full extent to which COVID had penetrated into the community and the factors that were associated with a positivity. The second point, beyond just generating the data defining the full extent to which COVID had penetrated into the community, was to be able to work with the community, a community of trusted individuals. And how do we do that? Well, we thought that the way to do that was to set up a community advisory group to help to inform our research, but also help to connect us with the community. Because after all, even though you know, I'm a Black man, I'm still seen as being, working in an ivory tower, and so it was important to be able to connect with the community through our community advisory group that consisted of leaders in the community, people who are plugged into community health centers like the Black Creek Community Health Center. And so through this, we were able to engage the community, get input from the community with respect to some of the things that we ought to be doing, and also engage them in asking some of the research questions that we had the tools to address. And in so doing, they saw themselves as being a part of the research. In this regard, this ongoing community engagement continues, and we still look forward to engaging them as we move forward in the next phases of the pandemic.
Thank you for that, Dr. Allen. I recall seeing the seroprevalence results from your study for the first time, and the results were really staggering in terms of the burden of infection. Just goes to show how important it is to dig into specific groups. I want to hear a little bit more the challenges with understanding burden of infection without having the right data. So can you tell us a little bit about what data we're lacking and the importance of having the right data for decision making?
Yeah, there data were lacking in from several perspectives. Number one is getting data that were aligned with some of the various ethno-racial groups that Joe alluded to, I think was really important. And I really want to applaud and thank Joe and colleagues for helping to champion the generation of this sort of data that we're able to tell what proportion of the population of Toronto, for example, was white, what proportion was Black and South Asian and so forth, and therefore how the proportionality of the COVID cases that were occurring aligned with their share of the population. And in trying to explain this to the community, I would say, for example, Shelly, well, imagine that the population is like a slice of pizza. The white population is entitled to approximately half of the pizza, and the Black population is entitled to about one slice. But you're getting two slices of COVID. And so we really had to break it down into terms like that so that everyone could understand. Having that sort of data that showed that the Black population, the South Asian population, and other groups were being disproportionately affected by COVID was extremely important, because we were able to show that with the engagement of the community, in the case of the Black community, specifically, we're able to show that things changed over time, that it certainly changed from having two slices of the pizza when perhaps you're only entitled to one, down to pretty more or less one slice of the pizza. And so that was really important. We were able to show, thanks to the data that were generated by the city, that when you look back at the cases of COVID in the city, the only populations that were not disproportionately represented were the white population and the East Asian population. And so all the other groups needed to have, attention directed at fixing that disproportionality.
Thank you for that. Yes, Toronto did provide some excellent data. Joe, I don't know if there's anything that you want to add. I assume that you were involved in that process.
Sure, and I would pick it up if we go back, early in the pandemic. So in early 2020, I recall at the time the then Chief Medical Officer of Health saying that we didn't need disaggregated data based on socio-demographic factors of race or housing status or others because COVID didn't discriminate. That was the position at the time at the provincial level. And it was in that context that we at Toronto Public Health decided that we were going to collect the data ourselves. And it's the old adage, what gets measured gets done, or what gets measured gets ignored. And in the absence of data, we could not do our jobs, both in the early days when we were measuring COVID rates and in the later days when we were measuring vaccine uptake. As we all know, and I'm sure as many people on this in this forum know all too well, that it was the social, in many cases it was the social determinants of health that helped to eliminate whether you got COVID or not and whether you got a vaccine or not. And so we needed to know what we were dealing with in order to respond, to reach everyone everywhere. And so we started collecting the data ourselves.
Thank you for elaborating on that. I think that we still need to understand all of these things from a social determinants standpoint to continue this work. Sabina, I'm going to turn to you. I've heard Upton say in the past that it's important when we're talking about communities to remember that we're talking about Black communities, not the Black community, because there's a heterogeneity of languages and cultures and barriers within each community. So in your role as co-founder of the South Asian Health Network, can you tell us how you tackled that?
Yeah, absolutely. First of all, I just want to say thank you for having me here today. This is such a great conversation that we're having, and also the collective wisdom that exists within Joe and Upton. I'm just, I'm enamored to be here on this panel with all of you here today. So thank you for having me. I first of all, the South Asian community is not homogenous. It's a rich, very diverse diaspora, right? And Dr. Upton spoke to the lack of that race-based data at the start. I mean, I live in Peel, and the earliest disaggregated race-based data that we had on COVID-19 showed that the South Asian community was vastly overrepresented. We made up 45% of the COVID-19 cases, but we only made up 30% of the actual population. And the issue really ended up being, well, first of all, the issue is if you can't measure it, you can't fix it, right? But then we did measure it. And the flip side of what can happen when we measure things and we see certain communities are being disproportionately hit is that the attitudes towards racialized populations end up souring, right? So South Asians were then being blamed and shamed for these high incidences of COVID-19 in their communities. There was a huge hit piece about Diwali parties, being the cause of the high transmission, when in fact it was simply all the structural barriers that the community was facing and had been facing, way before the pandemic. So things like lack of access to healthcare, precarious work, often with no sick pay, limited employee benefits, and of course, living in unsuitable housing. We know with the South Asian community, multiple generations are living under the same roof. And one of my co-founders of the South Asian Health Network, she's an internist at a hospital, and she would say at the start of the pandemic that you would see, entire families together admitted at the hospital with COVID-19. You'd have a grandma, you'd have the parent, you'd have, you'd have the child, you'd have essentially multiple generations in the hospital lying next to each other. And so we were seeing with our eyes that what was happening in the South Asian community, was dire and needed attention. And similarly, when vaccines were introduced, we saw significant distrust and hesitancy, and rightfully so, right? But again, our community were being then blamed for this poor uptake of vaccines, and we were literally watching the deficit model sort of play out in real time. And we know now that this one-size-fits-all top-down approach simply doesn't work. It's that horse is long dead. We've got to stop beating it. Instead, what we need are very targeted, very nuanced, culturally sensitive, hyper-focused campaigns. And it has to be multifaceted, knowing that vaccine hesitancy is not a monolith, and in fact is a culmination of a variety of different things like trust, things like digital literacy, things like language barriers, mobility barriers, and language barriers, of course. All of these things play a huge role into it. And so that's kind of what we set out to do with the South Asian Health Network, which ironically was actually formed after I wrote an opinion piece, really angry opinion piece at 2 o'clock in the morning, in response to Diwali parties, being blamed for the COVID-19 transmission in our communities. And so from the get-go, we decided that our focus is going to be ensuring that we were meeting people wherever they were. And the first thing we did was we created resources in a variety of different South Asian languages. And, there is so many South Asian languages, but we had to, because we knew exactly what the needs were in our community, which, communities within the South Asian had significant language barriers, we sort of focused on that. And we created a lot of these materials actually all on our own, to, the side of our desk. We were all healthcare professionals, but we were doing this in our spare time. And the reason why we did that is because we realized that a lot of translation agencies simply don't translate to the type of language that is actually spoken. And things were literally lost in translation. When we did, we got a small in-kind gift to get things translated, and we realized it was just simply not, meeting that language accessibility that we were looking for. And we also led countless vaccine education sessions for many South Asian community organizations within our community. And really what stood out to me were some of the conversations I was having at these sessions, the type of questions, that we were asked. So for instance, everything from, why should we trust the government's vaccines when the government hasn't done much to protect us up until now? Or, what about questions like what ingredients are available, are present in the vaccines? Up until that point, that question actually had not been addressed by any public health unit, right? But that was the first question we were getting in terms of animal products in the vaccines. And also people just flat out asking me, okay, you've talked about these vaccines, but have you actually been vaccinated? And then what I would start doing is posting a picture of my father and I getting vaccinated together at the Punjabi Community Health Services pop-up. And that, in fact, moved the needle so much more than, sometimes the 2-hour vaccine sessions that I would be giving. But, it really showed us that it truly is the power of representation when someone from your community who looks like you, who speaks your language, is telling you or talking to you, having this conversation with you in an authentic and genuine way. You're building trust as you're going, and that's going to pay off in spades down the road. And so there were many situations where we would have community organizations with less than 50% uptake of vaccines, and then post some of these conversations would actually go up to nearly 100%. So we were seeing some of that work happen in real time, and it was measurable in real time. And then what we did for the community at large was hosting many of these virtual town halls. We banded again with community centers in the GTA. At our peak, we had partnered with over 15 community health centers across GTA. And what we did is we had these town halls with South Asian physicians. And shout out, I took a peek at the participant list and I saw Dr. Dubey in there. So shout out to Dr. Dubey, because she did one of our sessions for us. And so we did these vaccine town halls. We got them synchronized in terms of simultaneous translations. And then we actually blasted them across Canada on South Asian television channels, so Omni, Y Media. And we picked peak soap opera time, so like 7 p.m., and we know that our brown aunties are going to be turning on the TV to watch the soap opera. We're like, nope, you're not doing that. You're watching our town hall. And the number of messages we got from our speakers saying that their distant relatives in Alberta and Vancouver, watched our town halls, was actually telling us that we were getting to people where they are. And We also did that with Punjabi radio because we know a huge percentage of the South Asian community are transportation. And so we targeted radios as well in Punjabi. And then we infiltrated a lot of the seniors' WhatsApp groups because if anything, I know from my dad, he gets 100% of his health information from WhatsApp, for better or for worse. So we knew we had to infiltrate that space. We collaborated with mandirs, with temples, with community orgs, with food banks. We essentially went everywhere, and that was what was needed, what we had to do to make sure that we were getting to everyone everywhere. As Joe said, he said, reach everyone everywhere, and that literally was our MO as well. And the other thing that we also did during those early days was ask the community what they needed and what they wanted and what were some of their biggest questions. For example, that question about vaccine products, we didn't know about it until we were actually having this conversation with the community. And I think, that bilateral communication is so important. And it's, again, something, I've done even with unambiguous science, but genuine engagement with the public, has to be based on trust, on mutual learning. I learned from you as you learned from me. That two-sided communication and knowledge transfer is so important, and that's what we tried to do with the South Asian Health Network as well. We knew we couldn't do it by ourselves. We needed our community to be there with us.
Thank you so much, Sabina. I think what I'm hearing is that communicating and listening actually help to increase vaccine uptake in these communities. And I'd be interested in hearing from Joe about the city side of things, knowing that communication is important, trust is important, and trust and consensus is hard to achieve even at the best of times. So Joe, how did your team simultaneously manage a crisis and also build consensus amongst all these different community partners, some of whom already felt marginalized and misunderstood?
Well, I guess, so I would sort of answer that in two parts. And, a lot of what you're hearing, I think, from all three of us here is the importance of building trust and breaking down barriers, both at the same time, right? Where clinics are, whether they're brought directly to people, who's doing the outreach. A lot of that is breaking down barriers to access. And then there's a lot of that is about building trust. So I would tell you from the City of Toronto perspective, part of it was, on the one hand, you wanted to have at all times, as much as possible in an ever-changing environment, clear communications, as much as possible. And I say as much as possible because it was ever-changing. And so it was a deliberate effort by at our order of government at the city to do those daily briefings that everybody was always a part. That remember when so many people were locked down, for those who weren't working on front lines in one way or another, every day there was like the federal briefing, then the provincial briefing, then the city briefing. We tried to have clear and consistent communications at all times with a few recognizable spokespeople, in our case, Dr. Eileen Davila, the medical officer of health, and our mayor and fire chief. But then clear and effective communications, not just in terms of daily updates from defined spokespeople, but multi-layered communications, to Sabina and Upton's comments, delivered by leaders in those communities. So that, again, around building trust. So clear communications, not just in terms of what the message is, and consistency of it, but who the spokespeople are on the ground. I think that was a lesson coming out of this. I think the other lesson for the city was we wanted to have, in the implementation of the vaccine campaign, a real coordinated effort, but done in a decentralized fashion. This is old school community organizing, right? If you're going to break down barriers and build trust, build on the existing capacity in communities that exists. The local community health centers, the local family physicians, the local neighborhood associations. And so that, when we talk about mobile clinics, so clinics had to be everywhere. What we found really worked was when those mobile clinics the locations were identified by the community-based leaders and often staffed by the community-based leaders. And so this was both from a layered communications approach, both consistency of message, but then ensuring that you had a diverse way of delivering that message to different populations, a community-based organizing approach to reach people where they were. I think those were, and that's not easy for a government to say, we want to have a coordinated, centralized system that's actually going to be decentralized in operation, but that's what proved to be most effective. And I would just say a lesson for future governments, effective insofar as you resource it. A lot of the work on the ground was done by volunteers. And if you want to address structural inequities, you actually need to resource people to succeed and not do it until they burn out. And that's an ongoing lesson I would argue is if we buy into the community-based model of helping to deliver services, whether they're health services or others, you actually have to invest in it. Otherwise, it will fall at the whims of momentum and burnout.
Can I just add something there really quickly?
Of course, go for it.
So I just wanted to, I don't know how I'm missing that when I was speaking, but Joe and Toronto Public Health were such supporters of the South Asian Health Network. I just want to make a plug for that because, again, like he said, amplifying people in the community that were already doing the work, providing them with the resources they need. We wouldn't have been able to do what we did without the support of Toronto Public Health and Joe in particular. So, I think a lot of what he's saying was not lip service. They literally did all of that and helped so many organizations doing this work. Anyways, I just wanted to say, so grateful. We were not able to do any of this without Toronto Public Health support. So huge, a shout out for gratitude to everyone on there as well.
That's amazing. I'm sure that that was a lot of hard work on the City of Toronto's part. It's very nice to see it recognized. And it's actually the perfect time to talk to Upton. Now that we're talking about communication and trust and engagement from within the community, Upton, can you comment on the importance of who is delivering those messages?
Yeah, thank you so much. I agree with a lot of what Joe said and Sabina. And again, I want to thank the City of Toronto, Toronto Public Health, for their efforts. And Sabina made reference to the South Asian Network. One of the things that was done was the setting up of a Black Scientist Task Force on Vaccine Equity. It was chaired by our friend Aquado Kenti. And this proved to be invaluable, to put it bluntly. It was really, really instrumental. Here, we had the creation of a group of individuals who connected with the community and who were seen as credible individuals. The committee the communities trusted. And so we had people from different, disciplines and who themselves had various connections with the Black communities in Toronto, indeed in Ontario. So it was really important to have a group such as a Black Scientist Task Force on Vaccine Equity. I was a member of that, Kwame Kenzie, as you know, and others. So who's delivering the message is really, really important. But the key is a point made earlier by Joe, and that is the multi-layered nature of the process. In this regard, we recognize that the process of delivering information to communities is one that involves a relay. It's like a relay race. It's a series of individuals, and the individuals have functioning at different levels. And so what we had to do was not only structure the message for the community at large, but also structure the message for the educators, so the leaders in the community. And so one of the things that, as it was a spin-off of this, myself and one of my colleagues, Isaac Adami, set up was a program we call program directed at educating the educators. And so this is really important to recognize that the ultimate goal is to ensure that people have correct information. And so it meant that we had to appreciate the multi-layered nature of the communication strategy. At the end of the day, Shelly, we, as far as vaccine was concerned, there are lots of misinformation that was out there, that is still out there. In the Black community, we wanted to ensure that if people chose not to be vaccinated, that they were not acting on wrong information. And so, and we made it very clear that we wanted to ensure that you have the right information, and that we didn't want a scenario or scenarios where individuals place themselves at the back of the vaccine line, if you will, simply because they were acting on wrong information. And I had a lot of experience in interacting with members of the community, and was able, along with my colleagues, to dispel certain, myths and wrong information out there that allowed people to move themselves further up in the line. And in fact, it was not just confined to the COVID vaccine. There are other vaccines as well. We had several anecdotes that I can, certainly, time permits, share with you. But at the end of the day, we wanted to make sure that the message was being delivered in a multi-layered manner, as Joe alluded to, by trusted individuals with connections in the community, and that people were getting correct information.
Yeah, misinformation is a big issue, and accurate information is so important. And Sabina, you have a lot of experience with that through unambiguous science. Can you tell us a little bit how you approached content during COVID and now, and who you are hoping to reach on the platform?
Great question. I think, it's really interesting. Social media is such an incredible, and we hear so much about social media being the cause of the infodemic and people getting so much bad information from social media. And I feel social media has been given this really negative lens, but I also think that we can, in fact, use social media to do exactly what we want in terms of increasing science literacy and scientific information, because you can have an enormous reach through social media, right? And I'll give you an example. I remember at the thick of the first campaign, there was a lot of confusion about Moderna versus Pfizer, and people were choosing to wait. This was during a time when we had a Pfizer shortage, and people were choosing to wait to get their second dose because they didn't want to get Moderna. And this is, I think we were coming into Delta at that time, and 2 doses was really where we were trying to get people to, but people were just opting to wait because they just did not want to get Moderna at that time. And I remember getting a text for some of my colleagues, one of whom was actually on the science table, and said, can you do a post about Moderna versus Pfizer, and can you get people, to be more comfortable with Moderna, which is really ironic because in the US, we were seeing the complete opposite, where Moderna, because of Dolly Parton, had like this elevated status. And we didn't have that here in Canada for multiple reasons. But, I ended up making a post. I talked a little about pharmacology, immunology, which were really areas that I used to work on before I kind of segued into vaccine hesitancy. And that post ended up hitting over 1 million people. And there's absolutely no way I could have had a conversation with 1 million people. And so I think that was the moment where I realized, okay, we can use social media to do good. I think the question is, how do we do it? And how do we ensure that we're using the right principles when we're using social media to communicate health information? And so I think, in terms of how I approached it, I had 3 core philosophies. The first one was to be truthful and to be authentic. And partially also, not to use government speak. I think that was one thing I really had to, with my background in biotech, was something I was more used to doing. So I had to step away from that. But I'll give you an example. You know, in the early days of the vaccine campaign, there were so many anecdotal reports of people who were reporting changes to their menstrual cycles. And, you know, unfortunately, we had health organizations come out immediately and say there was absolutely no correlation. And one of my earliest infographics that I created actually was talking about, while we don't know, you know, about possible correlation, theoretically, changes to the menstrual cycle can indeed occur, given that the endometrial lining is chock full of immune cells. But we also see minor changes in menstrual cycles with so many other things, with infections, with stress, you know, and even with other vaccines, for instance. But the important part is that we know that there's no downstream impact on fertility. And this is how we know why that there is no downstream impact on fertility. You know, and I think that was really important, because later when we did have data to show that these vaccines could cause very minor change in menstrual cycles, a lot of people felt that their earlier experiences had been invalidated, right? And so being truthful about what you know and what you don't know is really important, which is actually my second point, about being able to convey or talk about uncertainty. How do you communicate uncertainty? You know, we know, being in the science, that the only absolute in science is that there are no absolutes, and that things change, you know, guidance evolve. Which is a good thing. When guidance evolves, it means that we are keeping up with the information. If your guidance is not evolving, that is when you should be scared. And I think that, you know, we don't really do a great job of communicating uncertainty. And I think that really backfired during COVID, because we tried to give information as a very hard, black or white, you know, statements. And then when things change, as they do, a lot of the public, you know, were distrustful, and they didn't know how to trust or who to believe because of that. And so I think that there is an art in actually communicating uncertainty and what you know and what you don't know. And if that's done right, you actually build confidence and trust. So how do you do it without causing chaos, but in fact, building trust is really, really key. And then I think the third point that I would say is being nuanced, right? I think a lot of people are, you know, for better, for worse, really into some of these clickbait headlines, very often forcing decisions on people through fearful communication. And I think that's, you know, perhaps a lens sometimes public health takes. But in fact, you know, I think there's so much to be said about content that is balanced, where you're actually taking time to build science literacy, but obviously in a way where you're not succumbing to false equivalency and both sidisms. We don't want to do that. But how do you actually do it where you're nuanced and you're balanced, but you're allowing people to make those decisions for themselves based on the information that you're giving them? I think that, again, pays off in spades down the road, because you're building that science literacy from the bottom up. And I truly think that if we follow these three principles and just, you know, take up space in social media, I do think that we can be at a point where we can use social media for good, instead of, you know, I mean, social media is here to stay. It's not going anywhere. So what do we do now to actually, you know, use it to our benefit and to our advantage, versus lamenting the, you know, all the issues that we have with social media? I think it's going to be really critical, especially as we move forward.
Sabina, I feel like this is a call to arms for all of us to get on social media immediately. I see that we have 12 minutes left. We're just going to wrap up with one last question before we open it up to questions. For participants, the chat pod is open. I see we already have some questions. So thank you to all of you for pointing out the successes and the challenges and, you know, what we've learned. But we have a long way to go. We have a lot of things that we should be doing that we are not doing. We had some missed opportunities during the pandemic. Could I please hear from each of you one thing that we are not doing that we need to be doing differently now to engage communities and increase trust of equity deserving groups?
So I mean, I'm happy to kick it off. And this is upside downside. I came out of I left the city of Toronto 2 years ago. I left my position at the Board of Health at the same time. I came out of the pandemic and immunization campaign more convinced than ever that with political leadership, that with a whole of government approach, with financial resources to back it up, and by investing in grassroots agencies, that we can solve any problem in the city. I came out of the pandemic with this fierce optimism that we can tackle any inequity and any challenge with that combination, the same of approaches that we used in the vaccine campaign. That's the upside. The downside to your question of, what are we not doing now, is we have not entrenched the systems and lessons from COVID into this new stage of life, both into the ongoing delivery of vaccines, but also into tackling other issues. Diabetes screening, healthy eating. I mean, if we use the same reach everyone everywhere approach with political leadership and resources and a multi-sectoral approach, we can do anything, but we haven't. We have gone back to the old ways and people have got burnt out. And so that's the upside downside, I feel, is that we should build upon what the foundation that was laid during that era, but for many reasons, we sadly haven't. And I can place myself as part of that blame because I left.
Thank
Yeah,
you.
Shelley, I do agree with Joe 100%. I think, and you've heard me speak of this previously, Shelley, it's an opportunity for us to identify co-beneficial arrangements. So, and there are many examples where we were focused on COVID, and people would come up to us and say, well, can we talk about my blood pressure or my prostate, or my blood sugar? And there were examples. I think I told you, Shelley, about a case where I was actually enrolling somebody in a clinical study, and the wife turned to me and said, "Oh, this is great, doc, but can you check out my husband's prostate?" Right? So I just sort of plug them into the appropriate setup to have that done. So I think Joe's point is really important. We have to think of these opportunities to use the infrastructure that's been created to address not just COVID, but other health needs that the communities have. This is really important. And so it's an opportunity that we've missed to some extent, but it's not too late.
Maybe I'll take it in a slightly different direction, but I do think that, I do think that a lot of the vaccine hesitancy issues that we're seeing right now, I think many of us in the scientific community were just taken by surprise at the magnitude that exists. And I think that we're now at a worse off position at this stage of the pandemic, or post the acute stage of the pandemic. And I worry that, we're going to go back to a model of complacency where we're not actually putting in the effort to try and build back some of this confidence that has been lost on vaccines and also in public health in general. And I think we have so much work ahead of us to do, with respect to building this back. I'm also a huge believer in preemptive bunking. We need to be doing a lot of work on that front. We need to be building science literacy, and we need to be building back trust. And I think this moment is super critical, because I think it's going to really shape up what the next, few years are going to look like, and what our next response is going to look like. Because we know with climate change that we're going to see more and more pandemics. This is not the end of it. This is just the start. And so how do we actually better prep ourselves for the next pandemic is going to be really, really key. And the work starts now. It does not start when the pandemic hits, it starts now. So I really hope that, public health gets more funding. I'm going to put another plug for that, because we need it. And we need to do a lot of this work today, not tomorrow.
Thank you to all of you. I think we have time for one or two questions. So one is about community involvement with diverse groups and how you can establish trust and promote vaccine acceptance amongst First Nations communities. And I'm just going to say, I think this is really important, because this webinar was very much about Toronto. That is where we are and where panelists are. But of course, there are different places that have some of the same needs and some of different needs. So thank you very much to the person who asked the question for underscoring that. So this particular demographic faces significant mistrust stemming from historical colonialism and ongoing systemic racism. And so this is really a question about how you establish trust with First Nations communities.
Yeah, it's a very important question. We obviously need to engage the individuals who are well-respected and members of the Indigenous communities to ensure that, as we said earlier, the idea that the message be delivered by people who look like the community and speak like the community is really important. But there's one point that I wanted to make and it's something that I certainly learned, from listening to people like Janet Smelly and others, is that one thinks of Indigenous First Nations, the First Nation communities, and we often think of, well, they live in somewhere, and we got to go to that community, and forgetting the large numbers of Indigenous Canadians living in Toronto, in downtown Toronto. And so I think it's really important as we structure messages, we just need to remember that people don't live in necessarily in one little geographic spot. They're all over.
Thank you for that. There's so many great questions here. Okay, there's another question that talks about minority groups in rural Canada who may not have the same size of community as some groups have in Toronto, and whether there's any tips for building such connections and building relationships between individuals in these smaller rural communities.
So, I mean, if I were going to kick it off, I mean, I take a community development. I would take a community development approach to that question, which is to say, not dissimilar from what Upton was just speaking about in regards to Indigenous communities. You start with the people who are there. You start with build nothing about us without us, the old adage. And so building trust in remote settings, and whether you're dealing with a small community of 3, from a certain socio-demographic group in a small town, or a community of 300, you start in that community. What are the barriers? What are the trust issues? And how do we provide the supports and resourcing and infrastructure to support reaching this population, or support you reaching this population? You go to the people, start with where they are, build on what they know. And when the job is done and the job accomplished, they say we did it ourselves. It's that old community development.
I'd also like to add maybe to that. So we had a situation where, and I think maybe amplifying community orgs that are doing this work is really important here, because we had a situation where we had a small Indian community in Northern Ontario that didn't really have anyone else, any actual community center that we could anchor to, but somehow they'd heard of us, the local pundit in the area. So like someone that is very revered in the community had heard of us through connections, WhatsApp groups, I'm not entirely sure how, and reached out to us and said, hey, would you be able to actually help us with our community? Because we have questions, we don't really know who to go to get them answered. And so we ended up, asking, okay, can you tell us more about the community? What are some of the, languages that are spoken? And we had one of our co-founders who actually spoke that language do a session specifically for that community. And so I think that also having these connections is really important, but amplifying people who do this work works in a really good way, because otherwise we would not know about them, because we don't see them, we don't hear them, but somehow they heard of us and they came to us. So that, again, bi-directional is like so important too.
Thank you very, very much. I see we are almost out of time. I want to thank the 3 of you for taking time to chat with us this afternoon, for all of your insights. And I think I heard some optimism in there too. So thank you for that. And thank you for all of our webinar attendees for having your lunch hour with us. To stay up to date about the latest happenings in the immunization world, please follow us on LinkedIn and make sure to sign up for our monthly newsletter, and there should be links in the chat. So thank you once again to all of you, and we hope to see these attendees at events in the future.
Thank you for hosting.
Thank you, Shelley. It's a
Thank
pleasure.
you.
Thank
And
you.
pleasure to be with Joe and Sabina.
Likewise.
You guys are amazing.
No, thank you.
All right. I hope you have a wonderful rest of your afternoon.
You too.
Okay, take
care.
Bye-bye.
Bye.